Please join us.
मेमोरी का स्पेस आहे रेकॉर्ड
रिकॉर्ड करना पूरा record
पूरा होएगी
हो रहा है
तो फोटो का
Hello everyone. How are you doing? अरे खाना नहीं खाया अभी तक? और ब्रेकफास्ट तो किया रहेगा ना? नहीं किया? क्यों? Intermittent fasting कर रहे हैं सब लोग.
Yes.
Very nice. All right. So today's topic is very kind of hot topic. You might have seen there are so many news in the recent era, right? कि जहाँ पे young बच्चों को even as young as school going only 8-year-old or maybe 14-year-old or recently yesterday only we saw a news a 29-year-old man of Kerala actually died during scuba diving, right? You heard about that news, right? So let's see the case, all about those case and why these things occur, how to evaluate those patients, what are the important diseases which you should know in that perspective, what are the ECG findings in that things. We will discuss everything. There will be some questions for you, so I want you to be attentive, okay?
Yes.
Alright, so brief introduction, already they have given introduction of mine, thank you so much for that. So I have done MD in medicine, DNB in medicine, and I have more than 1 million community now across Meta, YouTube and Facebook as well. And I have founded Adrenaline Medit, it's a medtech app basically. And starting as a young boy in a town, a small town, if Sambhaji you know of. So, lot of difficulties, everything was so difficult, just like all of you must have faced at that time. And I had always dreamed that in one day maybe I'll be achieving something that makes my parents proud and has some name or some stamp of mine in this world. And I think I'm working in the right direction in that way. With that, I have been ranked 4th by the ET Healthworld. Also, I have been a TEDx speaker thrice. Along with that, I have recently found the DFA Foundation, which actually helps for the doctors as well as the patient. That's called as Doctors for All Foundation. Right? With the help of which we basically teach CPR. At the end of this discussion, you will understand that why CPR is also equally important. Just like what we teach in the school, right? Mathematics or other subjects, science, history, etc., etc. So just like that, even Food Power has also emphasized on the nutritional importance. But I think the same importance should go to the overall health, particularly heart health. Okay, because the number of the cases are so disturbing, and it's a toll for the family itself, right? So that's what my goal is, working on that thing. So we'll just show an introduction video about that. So here, this is basically school where I've learned myself, and the first thing when we started the CPR, all I could see these young kids basically, where I was one of them, and at that time obviously we didn't have that many resources, but yes, we made it through. So it's our time to give back to the community now. That's why we started the CPR campaign for them, and we successfully taught them, as you can see, without any without more of resources. We utilize whatever we have with the volunteering and all. We taught them, right? So let's start with the today's discussion now. When it comes to the sudden cardiac death, right, there are two misconceptions in all the people around the globe, maybe not the medical, but in general I'm talking about. So what do you know about the difference between the heart attack and the cardiac arrest? Anybody knows? What's the difference between heart attack and the cardiac arrest? Anybody? Yes? Okay, that's correct. Heart attack is basically ischemia, and when you have the ischemia in the heart rate increases so much, or the electrical wiring. If you guys remember in the physiology 12th, you must have learned that heart itself is an electric system. So that electric system gets disturbed, and because of that, heart suddenly stops. So that is your cardiac arrest. So most commonly, all these newspaper outlets, all the general public have this as a misconception. So that's what we're gonna solve today. Along with that, we will discuss 3-4 cases, after which we'll discuss the important causes for each of them, and we will emphasize more on the HCM and ARVC and also Brugada syndrome. Alright? So I just kept it concise, and so that you will also love the discussion. Okay? So let's start. This is the first case you might have seen. This is the news of the Times of India basically. On June 6 recently in 2025, this guy suffered the cardiac arrest during the scuba diving. Next case is about this young man who was a gym trainer himself. Okay, you might wonder that I will go to the gym and I'll be fit forever. Okay, so fitness doesn't guarantee your health. Okay, healthy and fit is different thing. So he also actually succumbed because of the cardiac arrest. Then you must have seen this video from the Ahmedabad, right? The kid basically in the 3rd standard died because of the cardiac arrest. Teachers and all tried to give CPR at that point, but couldn't revive her. Okay, so these are all news are so heartening. So that's why I'm just explaining you what is the importance of these things to know. Okay, so this is again the 4th case where was like only 14-year-old boy recently he was from Navi Mumbai itself, and he died in the Imagica theme park. You might have seen, right? So what is the common in all those 4 cases now? Yes? Anything? What do you think? Yes? No, actually, yeah, we can say it's exercise induced. That's also one more common factor. But what I am presuming to know over here is all of them are very, very young. Okay, all of them are actually they have not even started family at this age, right? So what's causing this? And that's why the importance of knowing all these things is there. Just imagine like we are working in day-to-day life, and suddenly there is a school game. I've played here on Terna turf a lot of times, and suppose like while playing football, some of our teammates might fall down. So then what would we do, right? So for that, all these things, it's very, very important for us to know that sudden cardiac death and what are the causes associated with it. So does anybody know that what is the most common cause of sudden cardiac death in young? Anybody? Yes? Fine. Okay. No issues. I will tell you. So basically, whenever you go into the heart, you should be very, very scared. Okay, that's the mnemonic behind that. Okay, we will discuss one by one. So first, let's discuss the scared mnemonic. S means your structural causes. Okay, structural causes means what are the illnesses there are in the heart. So either can be wall of the heart or electrical systems of the heart. And second, again, scared we say, right? C is called as channelopathy. First is structural, second is channelopathies, where sodium, potassium, different channelopathies can be there. Okay, so first let's discuss with the structural. Now I will tell you, this is very important MCQs for those who are preparing for the exams also, that the most common cause of death in the young population in India or across the globe is hypertrophic cardiomyopathy. Okay, HCM. Okay, so all of them were young. So let's discuss the causes. So as I mentioned, hypertrophic cardiomyopathy. Now as the name itself suggests, hypertrophic. Okay, ma'am is also there. We know the pathology. When there is a hypertrophy, there is expansion of the tissue and expansion of the muscle per se, right? And because of this expansion of the heart, you know there is a limited cavity in the heart, right? So when heart is wanting to pump the blood, now if the cavity is getting, it's like the muscle is getting enlarged and the cavity is getting narrowed. So obviously there is a less space for the pumping. And that causes this LVOT obstruction, and that leads to this kind of all symptoms. I will show you the animation also. I have added video for that. Amazing videos are there when we move forwards. Okay, so let's see that. So the first is hypertrophic cardiomyopathy. It's the majority of the cause, almost 35 to 40%. The next is rhythmogenic right ventricular cardiomyopathy, ARVC, what we call it as. Okay, so ARVC, just imagine like ARVC is just like a balloon basically. You are putting that balloon in the packet of, or maybe in the water. You can just think of that way. So in ARVC what happens, suppose this is the heart. So there is a fibrofatty tissues around the heart, and because of this the pumping or the arrhythmogenicity of the heart gets destroyed, and it basically affects your right ventricle. And which cause, in right ventricle you know that around above the right ventricle there is SA node, AV node, right? So because of this the arrhythmia occurs and patient dies. So that's the second most common. Then we have congenital coronary artery anomalies. Then we have primary arrhythmia syndromes like long QT syndrome, Brugada syndromes, WPW syndromes. I will explain each of them, don't worry. Then myocarditis, you might have seen after COVID, the cases of myocarditis are also on the peak, right? Many are blaming virus, a vaccine per se. Okay, majority of them are blaming the vaccine. So what do you think? Like, should we blame vaccine or should we blame the COVID per se, the COVID virus itself? What do you think? You think it's vaccine? Okay. Anybody?
Virus.
Yes? Just tell your frank opinion. It's okay. It's nobody's gonna judge you. Right? You think
Virus.
vaccine?
Virus.
Virus. Okay. Anybody else? Yes? From the back? You guys look studious, wearing apron and all. Yes? Vaccine. Okay, virus. Alright. So, see, when you go into the literature per se, the COVID virus itself is a prothrombotic. Alright. And when you give the vaccine, obviously it's derived from the COVID virus itself. So there is a substantial risk because of that. So you should not directly blame the vaccine itself, because yes, the amount of the people that have already received the vaccine is in the number of 50-60 crores, right? So even if you count it as a 0.1%, or incidence of the myocarditis, still the number becomes significantly high considering the Indian population, right? So that's the thing behind that. It's majority of the time it's because of the COVID virus itself or COVID infection itself, but even vaccine can cause. Okay, so that is this cause, myocarditis, which is the fifth cause for us. Then we have commotio cordis. You guys know commotio cordis, what is this? Anybody? So this is very, very interesting actually. Anybody? Okay, so I will just tell you the incidents. So in US actually there were two boxers. Okay, so one boxer was there. He had trained only the one punch. He used to take 100 punches and he used to give just one punch. Okay, and the other boxer was, obviously was maintained for the tackling. That was Muhammad Ali basically, for tackling the whatever boxers or whatever punches he gets. So the other boxer who has trained only to give one punch was always used to hit at the heart. Okay, always. He just used to hit only at one thing, that is the heart, around the rib cage in the left part of the heart or left part of the chest. What happens, if you guys remember the physiology of the cardiac muscle, do you remember what causes the cardiac depolarization? Which ions causes?
Depolarization. Sodium ions.
No?
Sodium.
Sodium and calcium basically, sodium and calcium. If you talk about the pacemaker potential, that's calcium. If you talk about the cardiac muscle, that's sodium, right? So what happens, during the depolarization, sodium comes in, and during the repolarization, potassium comes out. Okay, so that field is called as repolarization. Now, if you remember the physiology, in repolarization we had two phases. One is called as absolutely refractory or absolutely refractory phase, and relative refractory phase was there, right? ARP and RRP, if you remember. Now, if somebody gets the punch in that RRP phase, okay, some of the cardiac muscle is depolarized, some is repolarized, not all is repolarized. So during that time, if somebody gets the punch, okay, the heart will go into the ventricular fibrillation. That's the logic behind that. So he always used to hit at that point only, so that if patient goes into the ventricular fibrillation, he would die within just 1 minute after that. Alright, just knock out. Then they used to bring the defibrillator, etc., and used to revive if possible. Okay, there was incidents, one patient died also because of that. Okay, so then they got the rule that they can guard the chest or something. These rules then later on came. Okay, so that's your commotio cordis. It occurs because of sudden blunt trauma at the chest, and when your cardiac muscle is in the relative refractory phase, and that causes ventricular fibrillation. Same applies to the different arrhythmias. If you guys remember the ECG, ECG किसको आता है? ECG. Okay, so in ECG we have P wave, then QRS wave is there, then T wave is there, right? So T wave indicates what? Ventricular repolarization. बराबर है? So during T wave, if one more contraction occurs or R wave occurs, so because of this, again ventricular fibrillation can occur. That's called as R on T phenomenon, and that's also the same mechanism by which the arrhythmia occurs. Okay, don't want to go into that deep, but I think I'm just correlating with the physiology, so it should help you. And then last cause is substance use doping. Okay, so during taking cocaine, etc., it has been seen that it causes vasospasm, and because of this vasospasm, lots of death has occurred. So, as I said, whenever we talk about the causes for that, you should be very scared as this doctor is. Okay, so S is structural heart disease, C is channelopathies, that is long QT syndrome, Brugada syndrome, WPW syndrome. Then A is for the acquired causes like myocarditis, drugs or heat stroke. R is for the rare genetic disorders, even CPVT, Marfan syndrome. Then E is for the external trauma, that is commotion cordis we saw. And D is, if you don't know, label the cause as the idiopathy. Okay. So now these are the structural diseases, we have already seen this. These are the primary electrical. So in which long QT syndrome is there, Brugada syndrome is there, WPW syndrome is there, and polymorphic VT is there. So it might be little out of context to you about the Brugada or Wolff-Parkinson-White syndrome, but I will just give you a single clue with the help of which you can remember this. Okay. So first was long QT syndrome. So if you guys know that if the repolarization takes very long time, your QT interval might increase. Okay. So it can happen in potassium channelopathy basically. Okay. Then or even in electrolyte imbalances. Okay, hypocalcemia, etc. That can happen. Then talking about the Brugada syndrome. Okay. So in Brugada syndrome, what happens? Again, there is a repolarization issue is there. Okay, repolarization issue is there. There is a sudden depolarization during repolarization, and that basically occurs because of the sodium channelopathy. That's what is required for you to remember at this stage. Okay, so there is a repolarization defect, and because of this sodium channelopathy, the patient gets into the sudden defibrillation or sudden ventricular fibrillation, and because of that, patient dies because of the activity itself. Okay, then you have WPW syndrome. So WPW syndrome is little logical. If you remember the conduction system of the heart, from where the impulse is generated, which is the pacemaker of the heart? SA node, very good. So from SA node, signal goes to where? AV node. From AV node, it goes to where? Interventricular septum or bundle of hairs. Okay. From there, with the Purkinje fibers, it goes to the respective muscles. Now that is the normal your flow, right? Normal conduction or normal current flow is there. But what happens sometimes? If there is a in between, they have formed the accessory pathway between the atria and ventricles. Okay, that means direct connection for the current to go from the atria to ventricles. Now you remember, right? The atria makes the impulse generation at the highest amount, right? You know that, right? Atria generates impulse at the highest amount. When it goes to the AV node, it basically sets the rhythm. It's called as pace setter, right? But if you bypass the AV node, and with the accessory pathway, if the impulse go directly from the atria to ventricles, then obviously the rhythm will become more faster of the entire heart, right? So that's what called as WPW syndrome. Okay, I hope you understood the basic logic behind the WPW at your phase. How many of you are in final year MBBS? Okay, interns? Okay, कोई बात नहीं, ठीक है. Those who are in final year interns should definitely know, and the postgraduates also. Okay, that's the mechanism behind WPW. Then when we come into the polymorphic ventricular tachycardia. So polymorphic ventricular tachycardia is also one of the type that goes because of the long QT interval. The patient goes into the torsade pointe. Basically, that's the rhythm abnormality during repolarization that occurs. Okay, I think it's going a little above. And the last cause is acquired. As we discussed, in the acquired, we discussed the commotio cordis was there. Along with that, even patient, if you go in the extreme heat stroke can happen. That's also one of the cause behind that, because of the dehydration actually that happens. Then post-viral myocarditis like COVID, etc. That are the causes which we already discussed. And the last was idiopathy. Alright, so now we will discuss the one case we have. Okay, so one small case is there. Just to go into the deeper discussion of the hypertrophic cardiomyopathy, I have only added those things which are really, really important for you to know. Okay, so talking about the hypertrophic cardiomyopathy, first is this case. Let's see. We have a Rudra who was fit, athletic teenager with no known medical condition. During the second half of the match, he scored a goal, celebrated and collapsed on the spot. No chest pain, no warning. And bystander rushed him to the help. And then there was no ED available, so he was declared dead on the arrival at the hospital. Okay. Then when we did the autopsy, we found that there is a massive symmetrical septal hypertrophy. Histology showed myocardial disarray and fibrosis, and cause of death was declared as HCM. So this will be the typical presentation of the HCM you will have. And as I mentioned, almost 35 to 40% of the sudden cardiac deaths in young are caused by the HCM. Correct? Yes. So now the questions, there are several questions, right? If there is a hypertrophy of the muscle should be more powerful, right? Why the person's cardiac output reduces, or why somebody would die if the muscles are hypertrophic? right? We all work out to hypertrophy our biceps, right? Right? Who all work out here? एक ही करता है क्या? Okay, 3-4 are there. So you guys know, right? But you must be wondering कि why यार, मतलब cardiac muscle का hypertrophy होके भी still why patient is dying? So let's see the logic behind that. So first of all, what would have saved him? That's very important. Whenever you have the case and basically that succumbs, there is a meeting called as in hospitals called as mortality meeting. So in that mortality meeting, these questions will definitely be asked. That why before giving fitness to him, ECG was not done, echo was not done, who gave him fitness, okay, how could you give him fitness without seeing the ECG, echo findings or lab reports, okay, so that's what very important for all the young patients. We will emphasize on that later. But first question is why it occurs, okay. So that occurs because of the genetic condition called as hypertrophic cardiomyopathy. So in hypertrophic cardiomyopathy, basically, your sarcolemmal protein, okay, sarcolemmal protein, basically your cardiac muscle proteins are mutated, okay. So that happens because of certain mutation, and because of this, your heart muscle or cardiac muscles get hypertrophied, okay. We will see animation for that. Okay, so this is the case what we were discussing. Actually, this is a real case, okay. If anybody follows football, do they know about this player? Okay. Okay, that's Christian Eriksen basically. That was Tottenham's first player. He actually got collapsed on the ground during Europa. The same thing happened with him, but he later got better. He had the channelopathy. They managed it somehow with a pacemaker. Now he is better. But that was just a context to have. So, here we were discussing that hypertrophic cardiomyopathy, why it occurs. So as I mentioned, it occurs because of the mutation in the sarcolemmal protein. Now what are those proteins? Then if you're preparing for any exams, this question will be 100% asked to you. The number one mutation or most common mutation is MYH7 or beta myosin heavy chain. Okay, that is the commonest mutation that causes hypertrophic cardiomyopathy. I think for today's context, this mutation is very, very important for you to know. Okay, so whenever now you have patient and if somebody is giving you the family history that my brother-in-law or my brother or my father had the same incidents, okay, they collapsed during any activity or they were, shifting the stuff here and there or during working itself it happened. Then this is very important for us to do this assessment, okay, MYH7, alright? I hope everybody understood this. Yes. So after that, we will just discuss that why exactly the death occurs after the hypertrophic cardiomyopathy. Okay, I will just explain here. So we will just go ahead because I think you will be more entertained with the video. So as we can see over here now, see, these are the valves, okay? These are the valves of the heart, you can see over there. Okay, this is tricuspid valve from where the blood will go into your pulmonary valve and the pulmonary artery. And from there, your left atrium, the mitral valve, and the blood will go to the aortic valve, right? This is basic concept for you. Now let's see this is basically they are explaining the function of the heart. That heart basically pumps the blood to all the organs. Okay, now they will show you the ventricle or interventricular septum. Okay, this is interventricular septum. Does it have pointer? Anyway, so as we can see over there, the muscles hypertrophy is occurring now. Cardiac muscle hypertrophy is occurring. So now let's see what happens after that. So right, the interventricular septum will now go little there. Okay, so normally it was over here, but it's slightly moving to that side. And because of this is the cavity. See, this is the cavity basically. That cavity of, pushing the blood is now reduced. Okay, and during the same time, okay, as we can see over here, this is the normal. You can see the arrow size also, right? And that is the abnormal or HOCM patient. I hope you understood. So because that septal hypertrophy is there, the blood will not go in enough or adequate quantity to the other organs in the body and sometimes to the brain also. Okay? And most importantly, it gets aggravated whenever you are performing any activity, either playing football or you are stressed, maybe girlfriend. Okay, so any issue. Okay, when your catecholamines are on surge. So because of this, the heart rate increases a lot. And obviously, already your ventricles or interventricular septum is hypertrophied, and when the heart rate increases, the myocardial oxygen demand also increases. So more blood is required to the heart because the heart rate itself is very high. Got it? So because of this, then the heart, all the coronary muscles or coronary is basically, there is a poor perfusion to the coronary. Okay, and because of that, you get the heart attack in the HOCM patient. I hope you understood, right? Because the coronary perfusion is reduced, cardiac muscles will not gain enough blood, and because of this, patient will die. Alright? So this is what they are saying. In sometimes your mitral valve, this is your mitral valve, even mitral valve can move to the left ventricular outflow. That's where from the blood goes into the aortic valve and through the aorta to the other organs, right? But if the mitral valve comes into the way, that's called as obstructive HCM. Okay, don't worry. Even if you know the basic term that why HCM occurs and how it does it cause the LVOT, that's sufficient for you. Okay, so after that, what should we do? Workup, what is required? First is obviously the detailed clinical history that you have to ask that did you have any similar episodes in the past? Somebody in the family had the same thing. Okay, this is all very important for you. Then if anybody wants to go into the sports medicine, this is a hot topic for them. Okay. Then physical examination. In physical examination, basically, anybody know what happens to the apex pit in HOCM? Final year? Shifted, or what is the character of the apex pit? Not position, the character of the apex pit. Anybody? Okay, double or triple apex impulse is typically seen in this patient. Okay. So double or even triple apex impulse is seen, and sustained up or forceful apex bit is there. And there is also harsh systolic murmur because of the LVOT. Okay, but it is opposite to what we see in case of aortic stenosis. When we do the dynamic maneuvers, it might be little over above the head about you when we talk about the dynamic auscultation, but that's okay. So when we do the dynamic auscultation during Valsalva and standing, it will increase. Okay, that's very important. As compared to the aortic stenosis, when we do the Valsalva, basically AS murmur will decrease, but only in case of HOCM, the murmur will increase with the Valsalva and standing. Basically, that means you are reducing the load on the LVOT. Okay, so because there is a reduced load in the LVOT, there is a more turbulence and more murmur is there. Okay, this is the ECG finding which we can see in this patient. So I will just give you 1 minute ECG small workshop or something like this, where you will understand that what exactly is happening in the HOCM and what will happen in the other diseases. Okay, so if you know, this is the P wave, right? This is the QRS, this is the T wave. Got it? So in HOCM, basically, as I mentioned, the interventricular septum is hypertrophied, right? You agree with that? You saw the video? And whenever there is a hypertrophy on the left side of the heart, what will be the features called as? Left ventricular hypertrophy, LVH. So the patient's ECG finding will be more over to the LVH. Now you know, V5, V6 are the more leads toward the left side. And when we talk about the interventricular septum, V2, V3 are the more suggesting toward the ventricular septum. Alright, so in this patient particularly, you can see ventricular or septal hypertrophy is there. We can get it from this ECG appearance. But sometimes even LVH can also be there because of the constant LVOT. Whenever there is an increase in the pressure, you can see there is a hypertrophy. So because of this V5, V5, 6 also might go up. But here in this case, as there is only septal hypertrophy, V2, V3 will go high, and that's the important ECG finding in this patient. Apart from this, you can see there is a T wave inversion. Okay, in V1, V2 also. That's very important for us too. Okay, so this is the finding for the LVH and the HOCM, basically HCM. Okay. Thank you. Alright, so these are what the ECG findings we just discussed in the HCM. Then these are the echo findings in the HCM. Might be little in depth for you all. Okay, so this is how the echo looks in case of HCM. Basically, this is how your interventricular septum is there. This is how your right ventricle, this is your left ventricle, and you can see this distance basically. This is called as interventricular septum. Okay, and that IVS is basically enlarged in this patient. Okay, so we can also do the cardiac MRI for this patient, which will also denote the same thing. Okay, now in sometimes basically when you are monitoring any athlete or anyone wants to play or want to go into the athletics per se, you can also do the ambulatory monitoring. In ambulatory monitoring, basically you apply the ECG to the person's chest, and with that ECG, He can move here and there, he can play football, and you will get the continuous recording in the ECG. Now, if there is a HOCM, there is a high chance that there will be arrhythmias. That's what we discuss in the Holter monitoring. Okay, this is called as Holter monitoring. We can also do exercise stress test. If patient gets chest pain, we should, at that point only we should stop that. Okay, because of the ischemia, he might get chest pain. And genetic testing, as I already suggested, that should be done if somebody has the family history of HCM. Alright, then family screening should be done with the ECG and the echo, and it should start at the age of 12, or if patient is earlier symptomatic. Okay, so how do we manage this patient? So first we will do the lifestyle changes. We will recommend them that you should not play sports. And obviously we will give some beta blockers to reduce their heart rate. We will ask him to reduce the stress, reduce the heart rate with the meditation, yoga, all these things. Okay. So they should avoid the sports, etc., adequate hydration. You can avoid this. These are very important pharmacological. You should avoid these medications. And also when we go into the pharmacological therapy, the majority of the role is to reduce the heart rate, because what you saw, whenever the heart rate is high, there was increase in the oxygen demand requirement. Okay, oxygen demand is increased. So obviously because of this oxygen demand, there is a coronary ischemia, and that's how we reduce it with the help of beta blockers, right? We try to reduce the heart rate. Okay, it's basically the first line management for that, and we can give the calcium channel blockers like verapamil, disopramide. Then antiarrhythmics like amiodarone can be given if there is a arrhythmia. Okay, then finally we should give the ICD to this patient. This is implantable cardioverter defibrillator, ICD. So what it will do, it will detect that patient is having arrhythmia now, and now I should act and give a shock to the patient. So it's basically gets heart into the normal rhythm. Okay, that's the role about the ICD. Finally, we should do surgery. Okay, so if nothing works out, then CVTS surgeon will come and will just remove the part of the interventricular septum. Okay, that's the basic. Right? So these are some do's and don'ts that you should recommend to these patients if the HCM is there. Okay, so we'll just focus on the don'ts. So avoid competitive sports, no vasodilators and nitrates, because these are vasodilators and they will increase the afterload for the patient. Okay, then don't ignore the syncope, no preload stimulants or pre-workout stimulants. Okay, you might have heard about the Red Bull or Sting, etc. Right? So what they have in it is caffeine. Whenever you took caffeine, again there is an increase in the heart rate, predisposing the patient to such conditions. Okay, after that we have ARVC. In ARVC, I will just come to the main point. This is what is this wave? Anybody?
S wave. T wave, but T wave inwards.
Yeah?
S wave. S wave.
This is classic, actually this is an MCQ point. This is called as epsilon wave. Okay, this is the post-excitation syndrome. In pre-excitation we have WPW, and post-excitation it's your ARVC. Epsilon wave is there. Okay, so ECG finding, that's epsilon wave, that's pointed by the red over here. Apart from that, you can have T-wave inversions in V2 to V3, and there is a ventricular tachycardia in this patient's ECG. Okay. Finally, how do we manage this patient? In the same way, we are discussing ARVC now, which is the second most common cause. We will give beta blockers and we will advise them to avoid the competitive sports, and we will also tell them ICD is important if there is a risk of arrhythmias. Okay, so this is a simple mnemonic for that. ARV, fat for the ARVC. A is for arrhythmia, R is for RV, right ventricular disease, VT, and fat infiltration of the myocardium, which I already told. Okay, last case now. Just tell me, what do you think with this? A 28-year-old male software engineer found unconscious at 3 a.m. by his wife. He was gasping at that point, stiffening, then unresponsive for 1 to 2 minutes. So unresponsive male is there, 29. He regained consciousness spontaneously. There is no seizure history, no tongue bite, no incontinence. History of father died suddenly at 35 years of age in sleep. He was declared to have heart attack. There is no known medical history, and ECG is showing ST elevation in V2, V1 to V3 with a curved morphology. So this is the last and important topic for us. All of you will 100% get this question if you are preparing for any entrance in the world. Yes? Close enough, but ECG findings are not very prominent about WPW. Okay? So in WPW, you will have the pre-excitation syndrome. That is called as delta wave. Okay? That's called as pre-excitation. But here, we have V1 to V3 ST elevation with a curved morphology. So this is nothing but your Brugada syndrome. Okay? So this is the Brugada syndrome. It is also one of the commonest cause of the sudden cardiac death. This is basically included in the channelopathy causes. Okay, so first we will confirm that if it's really a seizure or some cardiac event. So if you have a seizure, how do you differentiate between seizure versus syncope? Anybody? Seizure versus syncope. What does syncope means?
Fainting.
Syncope means you can say blackout or brief lapse of consciousness or brief lapse of loss of consciousness. Okay, that's basically syncope. So if you have a seizure, there will be several things. Frothing of the mouth will be there, tongue bite will be there. Okay, and patient will also lose the consciousness for a longer period of time. Okay, he might have post seizure paralysis also can be there. That's called false palsy. Okay, all those things will be more prominent with the epilepsy. But when you have the syncope, most of the things will not be there. Okay, patient will just have the episode of blackout. That's all. Okay, so that's how first we will just confirm with it. Then we will get to know that okay, the cause in this patient might be Brugada syndrome, which will confirm with the ECG and the echo findings. Okay, so we will just do the ECG. So basically, this is the pathogenesis what we already discussed. Because of sodium channelopathy, there is a slow conduction of the RV outflow tract, and that leads to repolarization, heterogeneity, which leads to the arrhythmia in this patient. Okay, it eventually leads to ventricular tachycardia, ventricular fibrillation, which you guys know that is a deadly rhythm of the heart. Okay, so this is how the ECG finding looks in the Brugada syndrome. As we can see over here, type 1 is showing curved ST elevation, type 2 is showing saddle back, this kind of saddle back, and in type 3, this T wave is also very tall. Okay, so these are some classic presentation in the ECG. Okay, so the topic itself is kind of core cardiology. That's why I might see many of the confused faces and sleepy faces over here. But no worries. I hope those who are understanding are really understanding well. Okay, so last slide. I would just like to discuss with all of you that how we can prevent this incident. So what should be done, what government should do, what we should do as a student. What do you think? Anybody? Yes? Anybody from your group? What do you think needs to be done? To prevent the sudden cardiac death in India. Just imagine, just a girl who is in third is dying because of the cardiac death. So it's definitely preventable, right? It's preventable. So how do we do that? Okay, so you feel that only people who have a genetic predisposition should get screened. Anyone else? Yes, that's very, very important. Routine health checkup. Anybody else? If somebody is having sudden cardiac or somebody is having cardiac arrest in front of you, what you would do? Yes, so CPR training is required, right? For sudden cardiac death. Anything else? Before joining gym, before joining any schools or even participating in school athletic activity, okay, these screening should be mandated by the government. Okay, that's very important. The CPR should be mandated by the government in the schools, which is not there, which is there in almost all the schools in the world. Okay, so that's what I said. ECG, echo for all the athletes. Family history, if it's there, mandatory screening should be done. Never ignore the warning signs. Always educate them for the warning signs, and ensure the defibrillators are present everywhere. Okay, this is very important. In the schools, there are no defibrillators. I showed one case, right, that there were no defibrillators because of that patient died. So if defibrillators are there, it's very easy to use. You just take out the leads from that, you apply on the chest, defibrillator will identify the rhythm and it will say you that it's a shockable rhythm. You just press the button shock. When you press the button shock, the patient will deliver shock, that machine will deliver shock and patient gets fed. Okay, we have ourselves seen so many patients reviving because of this. We were working in the COVID eras actually. So at that point there was every alternate day we used to get cardiac arrest in the ICUs. Okay, and the last is educate that fitness is not equivalent to the immunity. Okay, so if you are immune, you might not get infection, but there are several other things rather than just infection which can make you sick. Okay, so that's all about this discussion. So this is actually presentation how we taught the CPR at this school. If we have audio, can you play?
Wait. You must be wondering how I ended up here. Well, it all started with a question I asked these amazing students. What would you do if your friend suddenly became unconscious? Some said they would splash water, others said they would take them to the doctor, but none of them knew the basics of CPR. In most developed countries, CPR is taught in schools from an early age. But here in India, it's still not common. So my wife and me decided to take matters into our own hands and started the CPR awareness campaign. Now these students were incredible, so full of energy and enthusiasm. They were eager to learn about everything from women's health and hygiene to something as important as basic life support. Next we got hands-on with chest compressions. I demonstrated the proper technique to the students and teachers, making sure everyone knew how to do it effectively without hurting anyone. And yes, one brave student even volunteered for the demo. We practiced doing 30 chest compressions followed by 2 rescue breaths again and again until the ambulance with defibrillator arrives. The energy in the room was infectious, and watching the students grasp the importance of CPR was unforgettable career moment for me. And just like that, we ended on a high note, 2 hands on the chest, CPR does the rest. Thanks for watching guys, please share this video.
Thank you so much. So, just the final quote, that greatness is never in doing more and more and more. Okay, it's in this doing same thing till you become the great. That's all. That's for my time, Dr. Vishal Gabale.